Okay. Excellent. Thank you, Circe. Good morning, good afternoon, good evening, everyone. Welcome to a wonderful webinar with the Boston Congress of Public Health. I am one of your co-hosts, Dr. Candace Carpenter, one of the co-CEOs of BCPH, as well as the Chief Strategy Officer. And I'll pop it over to my colleague.
Hi, how are you? My name is Dr. Circe Gray-Lecomte, and as my colleague said, I'm co-CEO of BCPH. Very excited about today's session, and thank you very much for being here.
All right, excellent. So today we're doing When I Say Health Equity with Dr. Miranda Ward. So I will do a little bit of an introduction to that, as well as some aspects about BCPH, but health equity. So Dr. Miranda Ward has her EDD as well as her master's in public health. She's assistant professor and director of equity in the Department of Clinical Research and Leadership in GW School of Medicine and Health Sciences. She's designing, evaluating, and teaching health equity curriculum for students as well as faculty. Her research is focusing on diversity, equity, and inclusion, justice, and anti-racism, educational interventions, as well as stakeholder-engaged, community-focused studies on HIV, Black women's health, and youth identity. She's a member of the DC Center for AIDS Research and a principal investigator for 2-in-1 HIV and COVID screening and testing model. And she's leading that as a national research-based educational intervention as well. So we're very excited to have Dr. Miranda Ward, but also know that for those of you who are attending our webinar, please take advantage of the fact that we are offering a number of different elite memberships with the Boston Congress of Public Health, as well as essential memberships. I know Circe may put some things in the chat as well in terms of we do have a special membership promotion. I believe it's $175 for 3 years to be a member with us. And that not only includes a number of different conferences that you'll be able to attend for free, but other things in terms of first dibs, in terms of being faculty for our public health leadership institutes, and many other things that we have as well. Our 40 Under 40 Public Health Catalyst Award winning programs, health innovation awards, as well as many of the other grant opportunities that we will be offering. All right, without further ado, Dr. Miranda Ward.
All right. Thank you so much for the invitation. I see the chat is lighting up with some of the places that you're logging in from. So I'm just going to go ahead and share my screen, and I'm going to pick up on this idea of where you're logging in from, because yes, I'm going to have this conversation of when I say health equity, what comes to mind, right? Because I really definitely want us to have a shared understanding of this concept, you know, especially since there really are no universal definitions. So I think it's really important, if we're going to have a conversation around equity, that we just go ahead and kick off this discussion with a decolonizing practice known as a land acknowledgement. So many of you are already, you know, putting into the chat where you're actually calling in from, but I'm going to just up the ante and encourage you, if you don't already know, to not only just put in where you're calling in from, but if you know the first peoples of the land that you're on, put that into the chat. I think that's really important as we really kind of, you know, really think about equity and the harms of the past, as well as, you know, even contemporary harms, and to, you know, in the spirit of reconciliation, really kind of name those harms of literally forcibly removing people from, you know, ancestral lands that they've sowed into and they've cultivated. So I'm actually calling in from Washington, D.C., and these are the lands of the first peoples known as the Nacotchtank tribe, and historians refer to them as the Anacostans. If you don't know the names of the first people of the land that you actually are occupying, you actually can go to this link. I know that it's, you know, the link is not in the chat. So at some point, maybe I can put it into the chat, or you're going to get a copy of these slides. But ultimately, there's this interactive kind of, you know, website where you literally put in your zip code if you're in the United States, and it'll actually show you what those, you know, whose ancestral lands those are. I think that's really important. So when I say health equity, the reason why I even, you know, kind of call today's discussion that I actually have an article that I co-authored with my colleague, Dr. Rohini Ganju, also in the School of Medicine and Health Sciences at GW. And we use that same, you know, title. And in that in that, description of health equity, we really kind of go through the nomenclature, right? Really understanding what are we talking about? When we say health equity and health disparities and health inequity, is it one and of the same? Should we use them interchangeably? So hopefully you had a chance to do that pre-reading. If not, then, I think that today's discussion is going to be the launch pad into, you kind of pulling up this article, and, you can share it with your colleagues, you can teach from it, and really kind of use it as a way to really continue having this conversation. Because it is really important to know the concepts of health equity, health disparity, health inequity are actually distinguishable from each other, but they are interrelated. So that's one of the things that I want us to cover today, so that we can be very clear on, when should I name something as a health disparity, or when am I actually talking about health equity, right? So we'll basically do that. And then we also have to recognize the role of social justice, which is why we kind of started off with this kind of a justice-based lens to our discussion of where we're calling in from, right? But justice is actually a tool. And so how do we achieve health equity? We use justice. And what does that look like in the public health field? And ultimately, what does that look like as we think about, the structural drivers of health, or what we call the social determinants? So that is, those are very ambitious goals for this 1 hour lecture. Still trying to leave some time for discussion, but the good news is that you do have the Q&A function. So as you ask a question, you don't necessarily have to, keep it in the back of your mind, keep it at the front of your mind, and actually go ahead and type it into the Q&A, and the moderators will be sure to pose that to me so we can just, have a robust discussion. So before we get into what is health equity and what is health disparity, I think it's really important to just take a step back.
Every document in life. Okay.
I think it's important to just go ahead and take a step back and just define health. Now, you may be wondering, like, what? I'm sure everyone who's logged in today knows what health is. But the thing is that I feel that us all living through COVID really reminded us that health is so much more than physical, right? Remember us having to be quarantined and socially distanced, like we really were reminded that there's definitely a social element to health, even though there's a tendency to only, kind of narrow in on the function of the body. Do we have a disease or not, right? But I really like this definition by the World Health Organization, because it really well positions how comprehensive health really is. It's social, and as we saw, like I said, through all living through COVID, that in turn affected our mental and emotional health, right? And then we know that also shows up physically. So I think, using the broadest sense of the term, when we talk about disparities in health, we're talking about the broadest sense of the term. So today's discussion most certainly is a public health discussion. And so to return to the example of COVID, I think that that's just a really great case study in what public health is. And for those of us who already know public health, you probably can recognize where I'm going with this. But those of you who may not be engaged in public health work, I'm sure you can agree that that was the public's introduction to public health, right? Because if we think about it, we really need to think about, not just our own individual patient's health, right? But the entire health of communities. And, like I said, thinking about how do we restore or maintain or protect the health and safety of entire communities? Well, there's a three-pronged approach. Again, let's use COVID, right? So we think about it, of course, we had to rely on research. Remember when COVID, there was all of the global research on the mRNA protein and all of the scientific kind of discovery that went into that. And as you know, we were kind of keeping up with the science as the virus basically kind of ravaged the world. And so we know that research is most certainly at the core of public health, because without research, research informs practice and informs policy, right? So because of what we learned from the research, we knew about the incubation period and how long, you were considered contagious and all the things, right? So that informed policy, like mandates, like, okay, you need to wear a mask, you need to be distanced, let's have a travel ban, right? So you see, you have research, you have policy, but one of the things that we learned is that it's not enough to just have research and policy without education, because you saw what happened, right? We entered into an era of disinformation. Absolutely. So you have to have education paired with that, or you will, find yourself having people trying to make interpretations without a scientific background, right? It's like, well, I don't understand science. So this study is saying this, but how do I make sense of that? How do I act on that for my health? And so that's why the three need to come to work in tandem. So I think that's really going to be important as a course as we kind of explore the concept of health disparities and attempting to achieve health equity. So specifically today, one of the things we're going to be talking about when we move into talking about health disparity, we're really talking about a population health metric. Okay, so when we say population health, it's not another way to say public health, but we recognize that when we say we are really concerned with the health of entire communities, there's different groups, right? Demographics that live in those communities, right? Women is a population, children are a population, people who are incarcerated, that's a population. So you see where I'm going with this, right? So there are different demographics or groups that cut across the different communities. And that's really important to recognize that, because when we talk about health disparities, we're literally comparing the health of one population to the other, right? So that's why we describe it as a population health metric. So when we talk about health disparities, let's be very clear. Health disparities only affect socially disadvantaged populations. So what that means is that health disparities are not happenstance. They're not just a coincidence that everybody in that group happens to have a disproportionate burden of poor outcomes. It's incredibly structurally engineered. And one of the ways I can show you how structurally engineered it is, I literally have taken the liberty of color coding, the themes that cut across, like the forms of social disadvantage that these entire populations are experiencing. And I want to be very clear that there's nothing inherent about any of these groups that would lead them to poor outcomes other than what we've created socially, right? So it's not biological, right? There's no, they naturally, no, it's unnatural, right? For them to have experiencing poor outcomes, but they are experiencing them because of social disadvantage. So let's go ahead and start with the very first one, and feel free to jump into the chat. So I want to know, what do you suppose that all of the groups, populations in red have in common that's a form of social disadvantage that would make them more vulnerable to poor health outcomes? Okay, so let me just read through the groups. So anyone that's considered a child or a minor, that's elderly, malnourished, immunocompromised, or not health literate. What's the one thing that they all have in common that's a form of social disadvantage that makes them vulnerable to poor health outcomes? Let's go ahead and turn to the chat and see what your thoughts are. Okay. So not all children and not all elderly people are low income. So we have some people who have, that live in wealth and they're older, or they're minors, or they are not health literate. Not everyone who's older or a child is ignorant. So remember, this one thing has to be, Lavita, let me go back up to the chat. Let's see. Lavita Joseph, you got it. You said that they are dependent. Let's think about that. Look at the ones that are in red. Why, each of those groups are literally depending on someone else to determine where they live, if they eat, what they eat, if they go see a doctor, right? Just think about it, right? So that literally serves as a social form of disadvantage that makes them more vulnerable to poor outcomes. Okay. Awesome. All right. So someone said this is implicit bias. No, this is well documented in the literature, right? That again, being dependent on someone else actually serves as a form of social disadvantage, which is why these are protected populations. Absolutely. Okay, let's move to the green populations. People who are mentally unstable, who are system involved or managing substance use disorder. What is the one thing? Remember, it has to cut across all groups. What is the one thing that actually serves as a form of social disadvantage? Oh, yes. Thank you so much for, yes. So yeah, you know what? And that is why, so Dante hit it on the nose by saying stigma. But I like let me just go back up to what Veronica was saying is, you know what? This is why I love having these conversations, because you're right. One of the things that happens when we talk about socially disadvantaged populations is that there's lots of coded language that gets attached to these populations, and therefore these populations are disparaged, these populations are pathologized, which is why I wanted to start off very clear by qualifying that, you know, these populations, there's nothing inherent about being in these groups that's making you more likely to have you know, there's no biological determinant that's like, you know, that's the reason why you have the poor outcomes. Absolutely not. The only reason is because we created social systems that disadvantage you. So, which means that we can undo that. We can mitigate that, right? So yes, thank you so much for that. So yes, Kiera and Dante, you hit it on the nose when you said that these groups are highly stigmatized. If you think about it, right? So regardless of if you are high functioning with your mental, you know, illness, or you know, when we say system involved, you could be in the foster care system, you could be incarcerated. There's just like, you know, different forms of, you know, institutions that you can be engaged, system involved in. Obviously, managing substance use disorder. Again, time and time again, there's going to be stigma and therefore discrimination amongst these groups, right? And that serves as a form of social disadvantage. Absolutely. Now let's go to the purple category, right? Those who are uninsured. And let me clarify what underinsured is. You very well could have insurance, but the insurance that you have doesn't cover all the things you need, right? So it's not enough. So you're underinsured. You can be living in poverty. You can be disabled. Some groups or some people refer to them as differently abled. You can be experiencing homelessness. And so, what is the form of social disadvantage that each of those populations are actually facing? Some of you mentioned it earlier, but it's basically there's a sense of disenfranchisement. Not everyone that has a disability is low income, right? So income level, I mean, it makes it harder to manage your disability if you don't have income, but income that's not a dependent variable in order for you, you know, for disability, because there's so many different disabilities, and you can be very well resourced and economically sound and have a disability, right? So so these groups literally are often stripped of you know, of their rights, which is when we say disenfranchised, that's what there's a like a tendency to try to strip them of their rights. And not everyone in those groups have low literacy, right? So there's nothing inherent about, you know, having a disability or not having insurance that makes you more likely to not be able to read or write. Okay, so then the final group is those who are racial, ethnic, or sexually minoritized. Wait, actually, you know what? Let me just put a pin in this because I want to explain why I use the term minoritized. Remember earlier, I told you that I live in Washington, D.C., right? And so in DC, the majority of residents in DC are Black. And even though majority of DC is Black people in DC are still referred to as minorities. So my question is, why? Why are they described as minorities when they're actually the majority? So someone may say, well, you know, DC, that's just a regional kind of statistic that doesn't represent everywhere in the US. Black people only make up 13% of the United States. So that's why they're described as a minority, even though where you live happens to be, you know, a large number. Okay, let's go further with that, right? Say that, you know what, since you wanted to zoom out and look at national rates, why don't we zoom out even further and look at globally, right? Globally, literally, let's hop from one continent to the next. Who lives there, right? If you literally visually jump from continent to continent, you will find that people of color are the global majority. And the reason why I bring this up is because when we talk about minority status, it's never a numerical status, right? Because we know if people of color are the global majority, but they're always described as minorities, we're not having a discussion about numerical status. We're having a discussion around social status, which is with this very discussion that we're having right now. This is social. And the reason why I bring this up is because I do remember that a couple of points were put into the chat around the role of power. If you think about all the social change movements around the world, whether we're talking about Arab Spring, whether we're talking about like environmental rights, whether we're talking about Stonewall, LGBTQ rights, whether we're talking about civil rights, so whether we're talking about Black Lives Matter, like it doesn't matter what the movement is, who is it led by? Socially disadvantaged populations. So we know that they have power. So this is not a question of, oh, these groups or they don't have power. They absolutely have power. So we have to be very careful in how we frame these discussions, which is why we're having today's discussion, because today's whole discussion is about language and the power we give to language and how we actually can maintain inequity given the very way we talk about it. Right? And the way we talk about those who actually are experiencing social disadvantage. So to go back to the point, people who are minoritized, right? They're not minorities, they're minoritized. What that does is shift the unit of analysis to the structural condition, and the social strata that actually ranks and sorts people. And so that's what's happening. So when they're racially, ethnically, or sexually minoritized, if they're refugees, they're asylum seekers, they're undocumented, they live in underserved rural or urban areas, or they can't read, write, or speak English, these groups are often overlooked. If you think about it, policy is not written with these groups in mind. No. Right? And that's why you see more and more efforts right now, like, oh, clinical trials to try to get these groups, right? And because they know that historically these are overlooked, systemically excluded groups. And so basically all the things that I just mentioned, right? Being a dependent, having stigma, having your rights stripped from you, and then basically being historically excluded, these serve as forms of social disadvantage. And this is the only reason why these populations experience disparities. So I don't know if you know, but the United States actually has a set of health goals. And we actually started it back in the 90s to coincide with our census. So as you know, every decade we have a census. And we started, like I said, in the 90s. We said, okay, by the year 2000, it felt so far away, we're going to, we recognize that disparities exist. So we're gonna aim to reduce disparities. So that was the goal back in 2000. But then we wised up and we realized that we probably shouldn't aim to reduce disparities, because that, that means that you're okay with disparities existing. You probably should aim to eliminate disparities, and any reduction would be progress, right? So that was the goal. As you can see, we want to eliminate them. By 2020, you see that not only do we want to eliminate disparities, we want to improve health of all groups. Let's go back to, health of all groups and disparities. Remember, not all groups experience disparities. The only groups that experience disparities are these groups. So if the group is not here, they're not experiencing a disparity. If whatever health outcomes they have, it's a naturally occurring health outcome that is biologically explained, right? You may be thinking of somebody that has, chromosomal, basically differences and things like that, that there's a biological explanation for that particular condition, right? And so we want to eliminate disparities amongst socially disadvantaged groups, but what about everybody else, right? We want to improve their health too. And that's where this goal to achieve health equity came for the first time by 2020. So obviously, it probably goes without saying, we have not achieved that goal. Okay, we have not eliminated disparities. We have not achieved health equity. So we maintain those goals now as we look ahead to 2030, right? And as you can see, not only do we have the same goals, we want to eliminate disparities, we want to achieve health equity, we want everybody's health to improve, but you see that we added attain health literacy. Now, let's be very clear, health literacy and literacy are not one and the same, right? Literacy is, can you read and write? But you can read and write and not be health literate. Just think about the fact that we're inundated with just so much information at our fingertips, right? Like we scroll through our phone all day. There's TikToks, there's, articles, there's like all these things, documentaries. And then we read just dinner table conversations, just like all of this information. And we have to process that for ourselves. What's our cost benefit analysis? How do I make sense of this and act on it for myself? There's lots of steps involved in that. That's a whole set of capacities. And that is why we actually have to be, intentional in building ability to be health literate. So let's get into the concept of health disparity, okay? So I will say, again, remember I opened up with this idea that, there's no universal definition. So in the United States, back in the 90s, when, we were looking ahead to put together our, Healthy People 2000 goal, we started to use that term disparity. And at the time, it was the Institute of Medicine, who now goes by the National Academy of Sciences, that actually kind of started talking about the racialized differences that they saw in health outcomes. And we'll talk about that landmark report in a minute. But that was the first time that we used the word disparity. And if you look through the literature, like literally, if you were to go to like Google Scholar and type in disparity United States, the 90% of the literature is going to focus on racialized disparities. Because, you know, that was the impetus for us looking into like these kind of unfair differences that we kept seeing time and time again in patient populations. But elsewhere in the world, they don't even use the term disparity. They use the term health inequality. And they're not talking about racial differences. They're talking about other differences. So for example, in France, they're looking at social economic differences, and in the UK they're looking at geographic differences, right? So they're not looking at the same thing. And I think this is really important because here we are as a global community, that we have a set of sustainable development goals, right? Remember the SDGs? And we say we want to end this, poverty and gender inequity and all the things, right? If we don't have the same metrics, like how do we know how far or if we're on target? Because we're not measuring the same things, right? And really what is actually the threat, right? So in the US, we're saying, okay, it's racialized. And then elsewhere, they're saying, oh, it's actually socioeconomic, or it's actually geographic, or some other metric. So it's actually all of the above, right? There's lots of things that actually are contributing to why you have the social disadvantage, right? Because all of that is social. And so, but the thing is that there's a tendency for us to only like kind of narrowly limit the way that we measure it. So like I mentioned, back in the late 90s, the IOM, now National Academies, they came out with a landmark seminal report called Unequal Treatment, that they recognized that, when we look at outcomes in our patients, they were looking at white patients and all patients of color. And they said time and time again, all patients of color, they seem to have poor access to quality care. And it wasn't related to clinical needs or patient preference. It was literally social, right? And so I will say that the NIH, they've actually upped the ante. They were like, you know what? You're right. There are healthcare disparities, which is what the, now National Academies had identified back in the 90s and early 2000s. There are differences in who has access to different, treatment and facilities and clinicians and all the things. But we need to tease out some of these, these unfair differences, right? It's not just having access to healthcare facilities. There's also just the disproportionate burden of disease, right? The actual epidemiological rates of incidence and prevalence, which is number of new cases, overall cases, right? So that's just literally like a CDC metric of what rate of people in this population have this disease, right? So that's why they tease it out. There's health disparities, which is, which like the actual diagnosis, right? Liver cancer, breast cancer, leukemia, like whatever it is, right? And then there's healthcare disparities, which is the access to the healthcare facility and the clinicians. And then there's health status disparities, which is really looking at quality of life, right? So sometimes it's not just, okay, do you have access? But then like, if you're in chronic pain, right? That also needs to be taken into consideration. So I mentioned that I'm in DC, and DC actually has an Office of Health Equity. And the way that they define these kind of unnatural health differences are tied to, again, social, economic, and environmental disadvantage. And they list all of the forms, like some of the things we talked about earlier, like which groups are actually experiencing this. But that's the thing, like I said, I could literally have a whole presentation on the multiple different definitions of health disparities. And instead, I'm just going to go ahead and come to the conclusion that I think one of the best definitions, because it's really straight to the point, is one that's offered by the World Health Organization. And that is made very clear that, when we see that there are differences in health that are unnecessary, they are avoidable, and they're also unfair, those are health disparities, right? So again, we're not talking about naturally occurring, like neurodiversity. No, that's naturally occurring. There's going to be different types of, people going to use their brain differently. That's not a health disparity. That is a health difference, right? So if we can attribute to developmental, like developmental differences, right? Bone density in an 8-year-old and an 80-year-old, like that's naturally occurring. So we're not talking about those natural, inevitable differences in health. We're talking about the unnatural, preventable ones that are unfair and only attributable to social disadvantage. That being said, that's literally what we were talking about earlier when you saw me color code, because I literally wanted to show you how patterned social disadvantage really is, right? So we've already made that very clear. So now I think that it's time for us to go ahead and do a quick review to see where you stand. Let me just look into the chat and see. Okay, somebody asked a question about the elite status. Okay, so you can just put into the chat if you think, so now that we've, really made clear that, health disparities are, again, we talked about it's a population health metric. It exists among socially disadvantaged populations. They are unfair and unnatural. Here are 3 examples. And now my question is, which one of these examples actually qualifies as a health disparity? Okay. Is it all of the above? Is it just, 2 of them? Is it none of them? Is it just one of them? So let's go over them one by one. Okay. So a person who has a rare blood disease that becomes chronically sick and at risk of premature death due to unavailable treatment modalities. So let me look into the chat. So far, most people are saying B, but Yolanda, let's see. There's A and B. Okay, let's see. Feel free to keep adding it to the chat. So let's go through A. For those of you who say, you know what? A, B, a lot of you have chosen B, but A is a worthwhile discussion of, potentially, okay. And then also Veronica, thank you so much for casting your vote. Okay, so let's go ahead and explore A. So a person who has a rare blood disease that becomes chronically sick and at risk of premature death due to unavailable treatment modalities. Now, it's really important, where you focus your efforts here. If you only focus your efforts on unavailable treatment modalities, because you're like, oh, wait, that's not fair. We talked about unfair. Okay, wait, but why is it unavailable, right? So if we look back up, it's kind of like, wait a minute, they have a rare blood disease. So the fact that there are unavailable treatment modalities, is it because of discrimination, right? Again, social reasons, right? Is it because, it's rare? And remember, health disparities are only socially explained. This is literally a biological explanation for why they don't have access to treatment, because it's a rare blood disease. So that's you have a rare blood disease, which is a genetic biological reason, which is a naturally occurring health difference. It's unfortunate that we don't have any available treatment modalities, but we have never seen this before, right? So that one does not qualify as a health disparity. But what really gave it away was that it started off saying a person, and individual people don't have health disparities. Remember who has health disparities? Populations, right? So you can't have a health disparity. I don't have a health disparity. An entire population, meaning entire demographic group, has a health disparity, right? So we already knew it wasn't, A wasn't right because it says a person. So that gave it away. Because remember, health disparity is a population health metric. So which group, right? Which socially disadvantaged group actually is experiencing this? And what's the social explanation, right? So for both of those reasons, that this is a person and there's a biological explanation, it's that we know we're talking about a naturally occurring health difference, and this is not a disparity. But if we move into B, like many of you have pointed out, someone talked about would fibroids be considered a health disparity? Well, remember, the question is the what qualifies as a health disparity is not the diagnosis, right? Does kidney disease qualify? Does asthma? No. What qualifies is which group is who's actually experiencing it. Remember, so health disparities only exist in socially disadvantaged groups. So we have to think about which population actually is experiencing higher rates of that outcome. So just the outcome in and of itself doesn't make it a disparity. The population having more of it for a social reason makes it a disparity, right? So the question is, well, with the fibroids amongst which group, right? Is the question. So yes, so then we can look at fibroids in Black women in comparison to any other group, and then you would see, yep. Thank you so much for that. And then someone else put, because of advances, wait, I'm sorry. Because of advances in research, people should not be dying of breast cancer. Thank you, Bintu. You stole the thunder. Okay, that's exactly what, that's exactly the point that should be raised there. Thank you so much for that. Okay, so let's get into that. Let's get into Bintu's point that Black women dying of breast cancer, despite having a lower number of new cases than white women who survive breast cancer. First of all, white women having breast cancer, they're more likely than any other group of women to have breast cancer, but they actually have a biological predisposition to it. The breast cancer gene. Did y'all know about the breast cancer gene? So again, they're not experiencing a disparity because well, white women have these high rates of number of new cases of breast cancer. That's a disparity. No, there's a biological explanation, and that's also not a socially disadvantaged group. Remember how we talked about that earlier? So they have a genetic predisposition. They have the breast cancer gene. But the great news, like Bintu said, is modern, advances in medicine, even with a biological predisposition, you're still more likely to survive. We have really, white women have very high survival rates because of, like Bintu mentioned, we have all of these advances. So then the question becomes, well, why is it that any other group of women can't benefit the way that white women are benefiting, right? That don't actually they have lower rates of breast cancer, but the group that has the highest rates has the high survival rates. So those high survival rates should be transferring over to every other group of women, right? Well, remember, for social reasons, because that's what disparities are, that's the only explanation for why Black women who are less likely, they have the lowest rates, right? But by the time they find out that they actually do have breast cancer, it's already aggressive, it's already spread. And it's because of social reasons like not getting the early detection and screening. That's 100% preventable. Like basically anybody that walks in the door say, okay, you know what, you're of this age, you should consider, just general practice, like at the PAP and, smears and things like that. Just get into the habit of doing breast self-examinations. But then by a certain age, 40 and up, you should be getting mammograms, right? And if that is not being offered across the board to all patients, not just, white women, that literally explains by the time they actually find something, it's already too late. It's already, in a later stage, and now it's aggressive and it's like hard to treat and they end up dying from it. And that is 100% preventable. So, and then let me see what the chat says. Too much like right to share the knowledge that's been treated for white. Thank you. Absolutely. Highest prevalence. They do have highest prevalence. Yep. So not all white women have the right. So we're not saying that all white women do, but the ones who actually have that breast cancer gene are the ones who would have the high rate. So I was just offering an explanation for, well, why is it that white women, like, what's the social reason that white women, there's not a social reason, right? There's a biological genetic reason why of all groups of women, white women have the highest rates of breast cancer, right? And that's why it's because of the breast cancer gene. So, all right, so perfect. I think I answered all of those questions into the chat. BCRA, okay, yep. All right, perfect. So the last one, higher rates of long bone fractures among skiers in comparison to non-skiers. I mean, you do have two populations. We did say that, health disparities only exist amongst populations, but are these socially disadvantaged populations, right? No, right? Skiers and non-skiers, absolutely not. It's not a socially disadvantaged population. So this is an inevitable kind of health outcome that comes with the sport, right? You're more likely to have a long bone fracture as a skier. And actually, people who ski are socially advantaged. Like skiing is expensive. So it says Black women are not told that breastfeeding reduces breast cancer risk. Absolutely. I love that point. And also Ayaba, who's my Spelman sister, by the way, Black women also have, and women of color just in general have more dense breasts, actually. So this also goes to training of healthcare professionals, right? This is why it's so important that representation matters when radiologists and other, those who are kind of reading x-rays and things like that, they need to be taught on a range of breast tissue because if you're not, taught to actually look and kind of find, okay, what is a breast cancer mass look like, but you haven't really used all of the different types of breast mass and breast tissue rather, then that's gonna be a missed opportunity, right? And so that's why it's really important to have the range of patients, reflected in the training so that they're not, missing that during those critical screening points. So ultimately, we made very clear, I hate to hear that, Cassandra. Yep, they misclassify, misdiagnose. That's real, absolutely. But again, I think some of that stems from the, not being able to read the dense breast tissue of women of color. So one of the things that we know that, these are social reasons. So we need to move away from our responses to these social kind of structural conditions and say, well, all you got to do is start doing this, stop doing that. Have you noticed that every time we talk about health disparities, our solution is focusing on individual risk behavior? That doesn't make sense. Individual people are not experiencing disparities. They are part of an entire population that's experiencing that disparity for structural reasons. So the intervention is not individual. So we need to move away from that. And we need to move into structural intervention. So I'm crossing out what we need to move away from, right? And trying to explain it away of like, oh, because, we got the funding and the infrastructure. We got the funding. We got the resources, right? It's all about allocation. So it's not that. We need to get to the root of what's really happening, which is inequity, when we're getting to our next term. And that's things like racism, redlining, segregation, mass incarceration, those big isms. That's what's at the rest. Those are the structural reasons why, these populations are experiencing the outcomes that they are. So here is a nice little matrix that really puts all of the concepts together, right? So remember, our goal as a United States is we want to achieve health equity. So that's basically this optimal idea that everyone should have a fair, opportunity to achieve what's possible for them. Notice the aim is not everyone be healthy. Healthy is relative, right? What's possible, biologically possible for me may be different from this person here, right? And the reason is because of age and just like a range of factors, like whatever I'm exposed to and the level of stress and, just our biology. There's just like all of these reasons, right? Whatever is biologically possible for you, right? Because you might have chronic conditions, comorbidities. That should be, that's why we say health equity is like, it's a focus on what's fair, right? Whatever biologically possible for you, you've achieved that. There should be no social reason, no economic reason, right? That you are not able to achieve what's biologically possible for you, right? And whatever genes, chromosomes, all the things that, whatever it is that you're born with or that you've been exposed to, right? Now, the metric to determine how far away or close we are to health equity is health disparity, right? This is a population health metric. It actually allows us to see, okay, here's all the different groups. Who has more or less, of that particular diagnosis? Fibroids, asthma, kidney disease, like whatever the condition is, right? Maternal mortality, right? So that's literally, you just compare one group to the next and you literally see the difference. It doesn't tell you why. It literally is just an empirical measure, right? So that's what what it is. Why they have the high rates is health inequity. That's what's at the root, the structural social reasons, the ones I was just talking about, right? All of the isms, any form of, structural oppression, all of these are created, right? And so, which means that they can be dismantled. And that dismantling happens through justice, through social justice. So this is like a pyramid that I think is really helpful, especially for those of us who work in healthcare and clinical spaces, because again, oftentimes you want to focus on, start doing this. All you got to do is, put on a seatbelt, wear a condom, eat right, move more, right? We want to focus on what individual people to do. That's what the individual patient education and counseling. That's important. We definitely need to wear seatbelts. We definitely need to wear condoms. We definitely need to get a vaccine, all things, right? So what I'm saying is, that has the smallest impact, if any, on health disparities. Because remember, you're talking with one individual person about their health behaviors, and what you're personally doing is not contributing to why an entire population is experiencing that. So if you like go all the way to the bottom, we're talking about social justice. It's injustice that's actually, it's the, the social attitudes that people have. You think about like cultural norms and, and gender attitudes and, moral beliefs, basically the way people think about the world, the way people vote, right? Like all of those are the things that move the pendulum. Like going back to all of the social change movements around the world, right? People have do you see generational change over time? Like people start to see, you know what, that's actually not right. And we probably need to make a change, right? That actually contributed to why we had, desegregation and all the things that were contributing to why we had poor outcomes in, certain communities. And that literally became, policy and law. And that is actually what has the largest impact. Now, you may, depending on what you do as your work, right? If you're a clinician or you're a researcher or, whatever the work you do, you may say, well, I'm not an activist. Like, that's like, what do you mean? I need to be out there. And there's so many ways to apply a justice lens to your work, right? Everyone doesn't need to be on the front, picket line or, calling elected officials. There's people who do that. There's whole advocacy organizations, but this is why language matters. The way you talk about, frame these discussions, that's going to come up in the ways that you think about interventions, right? So it absolutely does matter for you as a researcher to think about, okay, who's my target population and what exactly is the purpose of this research, right? And what are the implications? So again, research informs policy and practice. So if you as a researcher don't understand and have this framing language and understand which we're really up against are policy issues, not people issues, right? So that's why it does matter regardless of the work that you do. So you may be wondering, like, okay, you keep talking about these socially disadvantaged populations, but like, why single them out? What about everybody's health, right? Remember, health disparities only affect the socially disadvantaged group. So we want to, achieve health equity. The metric to get there is to eliminate health disparities, right? So if we need to really hone in specifically on those with worse health, because if we don't, we say, let's just do the health of everybody. Everybody is the standardized patient, right? Which is typically white men. And let's just be honest, with like, about the history of like the BMI and all of that is white men, right? And so you have a tendency when we say everybody, we use a standardized patient, and now we're actually widening the gap between the standardized patient, the one that we've normed, even though there's no reason to have normed that, and we need to dismantle that and literally be pulling in the attributes and the realities of all patients so that we can really meet patients where they are, especially the groups that are socially disadvantaged. So this is exactly why, if we think about the ADA, the American Disabilities Act, the definition, and I apologize that this is hard to read, but the definition of disability actually is not a medical one in the ADA. You're probably like, what do you mean it's not medical? They're not using a medical definition. They're using a legal definition. And the reason why they're using a legal definition is because without a legal definition, you're not able to focus on protections, right? That's why it doesn't matter to have a medical definition. So what we're really up against, going back to those social reasons, right? We have to have protections against discrimination because of stigma, because of these groups being overlooked and not being included, and all the things we talked about earlier, having their rights violated. So one of those populations are, LGBTQIA plus populations, right? And so we think about the injustices and therefore the, some of the disparities or poor health outcomes amongst this group, there's a range of things we need to do. One, we need to start to talk about sexual orientation and gender identity more and have an understanding of and actually measure them, because we're not even collecting this data in a standardized way, and that's how you even know that there's a disparity amongst this population. If you collect it, you have to actually have categories on surveys and instruments that actually measure this so that we can actually see if there are differences. But when we talk about cultural connotations, I don't know if you know, but the Pew Research Center, they said that about 1 in 4 U.S. Hispanics have even heard of the word Latinx, and only 3% of them use it. Now, this is an attempt to be inclusive, like, oh, we don't want to use gendered language, and Latina and Latino is gender. We want to be, we want to use all inclusive language. Let's just put the X. But again, this is why having cultural connotations and understanding of, even when you have the best intentions, you have to think about the impact, right? So it's like, actually, like the O is actually not gender specific. It actually means any gender, and you didn't know that. You know what I'm saying? So then people in that population don't really accept that terminology. That's really important, right? And whether we're talking about whether we're talking about language differences, or we're just talking about, this is why we have the plus, we say LGBTQIA, right? Because there's a range of ways that people self-identify. So I just bring that up because we have to just be really intentional about intent versus impact. So again, when we talk about creating health equity-based interventions, we have to be very intentional. It's just, oh, well, I do health promotion, I do, prevention. That's not the same as health equity, right? You have to explicitly focus on social disadvantage and making sure everyone has this fair opportunity, right? And one of the ways is by really honing in on opportunities for health. A prescription program is one of those, it's like a national movement where clinicians across the country are actually prescribing PARCs. And, parks have so many positive kind of, associations. It's not just, oh, more oxygenated, air, and, you're more likely to, be social when you're outdoors and moving, all the things, right? There's like a range of literature that comes with that. But this is the thing. You can do that and not understand that, well, maybe some people don't have access to green space, or it's not safe, or, right? Which is why understanding the social determinants are so incredibly important. When we talk about the structural drivers of health, people have a tendency to only think about healthcare. Healthcare is only 20%. That only explains 20% of your health outcomes, right? The average person doesn't live in the clinic or the hospital. I mean, some people do, right? But the average person doesn't. So they're dragging with them all of the other things: economic stability, the built environment, food, right? It's all the other things that literally is, it's 80% that's explaining their health outcomes. So this is why there is an ICD-10 code, a billing code, so that clinicians literally can spend the time getting the social history, right? Instead of saying, okay, well, we're here just for the clinical diagnosis. I'm just going to, bill for that time. I don't have time to talk about, non-medical factors. Actually, you can bill for that time, because as we know, that is so incredibly important to understand if people are housing secure, right? If they have food, if they, the quality of their social, environment and psychosocial support, like all of those things are incredibly important, which is why we now have we have built that in to the system. So I'm going to end with this idea around asset-based community development, because I think about that oftentimes when we talk about disparities, again, there's this kind of like focus on gap and need and lack, but the community is closest to the problem, which means they're also closest to the solution. So to give you a DC-based example of, using assets to really develop the community, on the left, you'll see this is a map of DC, and everywhere you see a star is where there's a grocery store, and the circle represents the radius, what we call like a food desert, right? How far it is to get to that grocery store. So that shows you where all the food deserts are. But that's the thing. If you ask the community members, what's an asset in your community? You may be thinking, oh, a library, or, a firehouse, the corner store. Okay, you're probably like, a corner store? Absolutely, because there are plenty of them. Okay, so a brick and mortar building, you have all these corner stores, convenience stores, basically all throughout the community. And so those are local business owners that literally partnered with local urban farmers to literally outfit their corner stores to be a healthy corner store. So now, since people don't have a full service grocery store to go to, but they got the corner store, they can actually get fresh produce there now because of partnerships like this. So this is an example of how, okay, you know what, you may have higher rates of hypertension or diabetes or XYZ in some of these communities because they're in a, underserved, urban area, which again is a health disparity. But the solution is not, well, all you got to do is eat better. No. All we have to do is, make sure they have food access. And that is an example of these kind of community partnerships that can address these structural, conditions. But we recognize there's lots of ongoing challenges, right? We haven't even talked about all of the, just like historical trauma and the impact of, all of the isms. And, the American Public Health Association, the American Medical Association has named the racism as a threat to public health. And so that's one of the reasons why even at the School of Medicine and Health Sciences at GW, we're moving away from race-based medicine. We have a curriculum committee that have named, ways that we really should be talking about race in our conversations. So I'll go ahead and end there so that we have some time for some questions.
Awesome. Well, I'll reiterate what I think many people in the chat have been saying. Excellent lecture and conversation, Dr. Ward, for sure. I'll go ahead and if you haven't gotten to this one already, there's an anonymous comment. I love this talk so much. Any hopeful thoughts as we move into a hostile political climate? Like in some places, we can't even say the D or E words, diversity and equity.
I know, right? I do realize that that most certainly is a challenge. And so I think that one of the things we're going to have to do is just be creative, and we know that DEI, DEIJ has been under threat for a while now. And obviously with the changing of the guard, that most certainly is more in our face. And now the thing is, I never treated DEIJ as a topic, right? It's not like, okay, so now let's talk about diversity. It's like, it's been integrated into the conversation, right? We were already talking about a range of populations. We were already talking about the harm that's been done, right? So I feel like there's ways that we think of DEIJ as a set of values and as a lens to the work that we're doing, then we won't feel like, oh, they're going to strip my ability to talk about it in the classroom or to bring it up in the, in the meeting or to, address it in the policy. I feel like if we, use it in that way, then we don't have to worry about necessarily, not being able to kind of really address the issue at hand.
All right, great. Second question, what is the strategy for moving forward then in 2025?
That's a big question. I think, this is one of those starts. Thank you so much, Boston Conference of Public Health, for even providing the space for this very conversation, a framing conversation. It's so important the way we talk about the, these concepts. So for example, I love that I work in the medical enterprise at GW, and we actually have a group of clinicians who say, you know what, we're literally going to stop using the word non-compliant. And I was like, I love that. Let me tell you, there was literally a study that Health Affairs put out that showed that coded language was more likely to be used in the patient charts of patients of color, right? So they're more likely to see words like difficult and non-compliant in a Black person's chart or a brown person's chart. And that's the thing. Clinicians, the first thing they see before they even open the door and introduce themselves to you is your chart, right? So if these descriptors are in there, that's already coloring the way they're going to receive you. If they're going to, share with you a range of treatments and all the things, right? Screening, if they're going to invite you to be in the clinical trial because they're like, oh, they're difficult. Oh, here we go. So they're already gonna, yes, thank you. Non-compliant, misunderstood, right? So the thing is, which is why we have to talk about the social determinants. It's like, are they really non-compliant? Or is it that they're facing food insecurity? It says to take this 3 times a day with food, but I can't eat 3 times a day because I don't have, so that's why we have to understand the social context that people live in. And it's not really a patient, again, these aren't people issues, these are policy issues. And so this is why we have to talk about those structural drivers of health and stop labeling and disparaging patient populations and really get to the crux of the matter.
Yeah, absolutely. And then I don't see any other questions, but I guess a question for me. I love the last part that you were saying, like the changing in the curriculum, right? And having to build in those aspects of the social aspects of people, right? And I know when I went to medical school, that wasn't really there. And it was basically like, to be more objective, we don't talk about those things. But if we don't, then we're missing things that are very important, right? We're not talking about health disparities. And then we're not talking about how we can potentially solve them.
Right.
Yeah. All right. Well, if there aren't any other questions, Dr. Miranda, thank you so much again. Wonderful conversation. I also want to give a shout out to Dr. Ward. She will be at our conference that's coming up in the next couple weeks with BCPH. So make sure that you tune in for that. Like, we are focusing on AI in medicine, AI in clinical research. So Dr. Ward will also be presenting there as well. So make sure that you check that out. All right. Well, everyone have a great morning, afternoon, evening, wherever you are, and be blessed. Thank you again.